Hello, good people. David here, and today I'll be talking about community pharmacists. Okay, so this session will cover maybe what community pharmacists want before they offer public health intervention, and we'll be looking at different things, maybe around health economics, data science, and yeah, that kind of field in short. So this is a paper review, and it goes all the way back, not very far actually, in 2025, where an experiment involving Kenyan pharmacists was conducted to determine what they actually want before they offer public health intervention. So, a little bit of background is that in Kenya we have around 11K pharmacists registered by PPB, and they offer public health interventions including HIV testing, family planning that help, for example, in reproductive health goals, and also point of care testing. Okay, so that's a bit of the background here. So for this paper, this was a paper done by Mumbi et al. From KEMRI. It's a health economics research paper, and the title was to identify community pharmacists' preferences for attributes of public health interventions in Kenya. It is what we call a discrete choice experiment. Okay, so the problem here is that uptake of PHI, public health intervention, is normally inconsistent in our setting, and pharmacies again are largely missing from the national health strategies. So this experiment was done to ask what do pharmacists want for them to be involved, or for them to continuously pick up PHI, and in doing so, can this information help us think in a better way of how to design public health interventions for pharmacists to pick up? Okay, so this experiment involves 663 pharmacies. Just a little bit of background: there are around 1,400 pharmacies in Kenya, serving a population of 4 million. Okay, this is again is based on 2019 statistics, which things have changed since then. It was also done in Kisumu and Makueni, where the baseline pharmacies by then were around 250 and 100. So the whole idea of this experiment again is to flesh out what do community pharmacists actually prefer before offering PHI. What would they choose when forced to trade one thing against another when offering PHI? Okay, so a little bit of background. I won't dive deep because this is health economics, not my territory at all, but we will be trying to see some interesting things, and in this case I'll talk a bit about the discrete choice experiment and maybe the modeling aspect of it. Okay, so this discrete choice experiment is grounded in what we call utility and random utility theory. Basically, the model takes what we call total utility, which is equals to systemic observable utility, which is a function of the attributes and parameter betas we estimate, and then plus epsilon IGS, which again is a random observable part, everything you cannot measure. So this is maybe stochastic, an epsilon or an error term. So I won't dive deep into the math of this. However, let me just come here and talk about this aspect. Okay, so in essence, we normally deploy a DCE when we cannot observe people choosing their revealed preference data. So think about this: it's Monday, you want to go to work, and you have to choose between taking your car or or your public means of transport. Before you make a choice, there are things that come into play, i.e., the time, given the traffic, maybe the what else, whether you are late or not. So there is some sort of variables, or let me say parameters, that are involved before you make that choice. The choice on Monday can be different, for example, in the choice on Friday. Maybe the choice on Friday is there's no traffic. So that is that will inform whether you choose either one of them. Okay, so in this case, we employ that thinking in what we call hypothetical market to describe alternative features, which we call attributes. So here we ask people to choose, and from those choices we infer the value people attach to each feature and the trade-offs they will accept. Okay, so just a little bit of definition here. An attribute is a characteristic, either good or service, that matters to people, i.e. profit margin, if there's training required. And then there's what you call level. This is a specific value an attribute can take. So for example, a profit margin can be between 0 to 15%, 15 to 30, 30 to 45, 45 and above. Okay, so the combination of one level from each attribute is what we call a profile. So in this case, when we take the example, for example, of we take our example of whether you want to choose using a car or a matatu for transport, be it on Monday or Friday. Let us try to bring that analogy here and see what's happening in this case. So in this case, think of public health intervention 1 as your car, and public health intervention 2 as maybe the matatu. And in this case, there are some attributes that we have described here. So maybe the time taken, maybe the cost of fuel, maybe those are what we call attributes. Okay, so before you choose one, there are things that you have to consider. So this is the same thing that happens with public health intervention. Before a community pharmacist chooses which public health intervention to take, at the back of their mind, there are some things that they have to consider. All right. So in this experiment, we come up with these attributes, and then we come up with these margins or these levels for them to choose. I hope that makes a little bit of sense. So this is a more honest survey compared to the normal survey. So for example, if I ask you which is the most preferred method of going to work, and then I say car 0 to 10, probably say 8, and then I'll say okay, so and so prefers using a car 8 times out of 10. But when I do it in an experiment manner, I can able to get more details as to maybe why you prefer a car. Okay, so this is the same thing that people use, for example, to design drugs, insurance plans, health worker recruitment strategies all over the world. So that's everything about DCE in a nutshell. All right, so back to our study. So in this study, Mumbi et al. Used this methodology over here, and for us to get the attributes, first there are two ways to go about it, and then we combine the two ways. First, we do a literature review, where here they got around 6 attributes, and then second, we do a co-creation. So in this co-creation, because we want this to be homegrown, they did an in-depth interview with 26 providers, and in this case they got 8 contextual attributes. All right, so then they combined and then they removed the inappropriate attributes, and then they launched sort of a pilot study among 36 pharmacies. So by doing so, they came up with these attributes of the public health intervention. So every public health intervention could have, for example, the nature of the intervention can be either simple or complex. There's public health intervention that require training, some don't. Okay, some require government support, some again don't. This support can be either regulatory or financial. Then there is profit margin that comes with public health intervention. Also, there's a cost of the equipment that comes with the public health intervention. So the question here is, for a community pharmacist, before they offer public health intervention and they have to think over these attributes, what is their thinking like? All right. So to do that, we sort of do the pilot, which is, again, they did it with 36 pharmacies, and they use something what we call a Bayesian efficient. Again, I want to go deep into this, but simply a Bayesian efficient is a statistical approach for planning experiments that uses prior information about unknown parameters to create a more informative design, maximizing data value while often reducing cost. So in this case, think of it this way. This pilot pharmacies was used to provide what we call priors to inform our final design, which was using a Bayesian D efficient. Okay, so this is the statistical value that we'll be presenting in this data to say if something was statistically sound. Okay, after that they did sample size calculation and then statistical analysis using the utility model. All right, so on the results, I will skim briefly through the results, but in essence, the results provided what we call coefficients. So these coefficients, in a nutshell, what they basically was trying to communicate is, number one, pharmacists do not want to opt out on providing for public health interventions. Remember here when I showed you this, there is a choice here of PH1, PH2, and none. So most pharmacists actually answered either one or two. They did not want to choose none. Okay, so that's number one. So the opt-out coefficient was strongly negative and highly significant. Then number two, to make a typical pharmacist stop offering public health services, you'd have to more than quintuple their profit margin. So in this case, that means that for a normal pharmacist, for them to opt out for providing a public health intervention, their profit needs to be like times 4 what they are receiving now. Okay? All right. Then next thing is that profit margin is by far the biggest driver, which is positive and significant. So that's something important that I want you to internalize. So in this case, we see that profit was the most significant factor that determines whether a pharmacy picks up a public health intervention. Okay, we will dive into that more as we go along. Then on this other side, you also see that complexity is heavily penalized. So you can see here we have a negative. So the willingness to accept calculation. So in this, it's a calculation parameter that I haven't talked about, but the willingness to accept an intervention suggests that you'd need to add about 11 percentage points to the profit margin for pharmacists to accept a complex intervention. So what does it mean? In this case, from this experiment, they showed that, number one, pharmacies don't like complex interventions. And if they were to accept a complex intervention, you'd have to add about an 11 percentage points to the profit margin. So if I'm to take anything complex, then that complex thing needs to come with something called an 11 percentage points to the profit margin. Okay, so from this we can see that programs that add complexity must match with the price compensation accordingly. Okay, so that's number one. So this is the first bit of the results. So over here, just to show the results from these plots, you can see that profit margin was the relative most important attribute for public health intervention. So that means that this was very important for pharmacists to consider before offering the service. I know you might say, yes, this, like you'd expect to see this, but we will dive deep into this and see maybe why this actually makes sense. So other attributes include the nature of intervention, training, cost, and government support. And it's interesting that government support was actually the least thing to consider for community pharmacies. So that's one thing to put in mind. So we can see the community pharmacies providers in Kenya operate, number one, as private practitioners. That's why maybe you'd see that they want to increase their profit margins because they want to be able to be in business. They want finance to run the operations. Then PHIs that include financial investments, incentives to enhance the scale up of community. So we can say, okay, sorry. So here, this is an important point. PHIs that include financial incentives to enhance the scale up of PHIs in community pharmacies in Kenya need to be considered. So over here in government support, there are two types of government support that they were offered. So if I come back, you can see here that government support could either be financial support or regulatory support. Okay, so in this case, what this result meant is that whenever it came to government support, they really didn't care much. They only cared if it was financial support from the government, even though government support was amongst the least amount of thing that they'd care. So this is an important factor because it means that majority of the public health interventions that come from the government side are not more so adapted by community pharmacies. This is not something new that we are seeing from this paper. Maybe it's something that has also been happening, but for it to be reported in this manner, given that we are comparing different public health intervention helps us think better when we want to design or we want to urge public community pharmacies to pick up this public health intervention. So from a regulatory standpoint, it's very important for government or regulators to really think on how to make this statistic go up for them. I think that is what I wanted to discuss. That's why I had this point over here. So amongst characteristics of the PHI offered include blood sugar testing, blood pressure measurement, vaccination services. Again, showing the kind of services in which pharmacists take part in. Again, this is not new, but also to keep in mind. You can see how small things are the ones that pharmacists maybe would like to take part in, and how these factors or how these characteristics of PHI are the things that actually drive their profit margin. So if I were a community pharmacist looking at this video, I'll probably think to myself, okay, if I want to take part in a public health intervention, then I would more so take part in this kind of intervention, given that they are in keeping with margins of operations or profit margins of operation. Okay? Or don't take advice from me. I'm not a health economist. But anyway, that's just on a light note. The data speaks for itself. Okay, so the most important thing I think from me, what I took out from this paper is that even though we are seeing this kind of output, there is something else that the latent class analysis was able to do or to reveal. And in this case, we are able to see that there are three types of pharmacies. So this average kind of plot or distribution hides some things, all right? So they run a latent class analysis, which is a method that lets respondents fall into unobserved segments. So in these segments, we have three segments. We have three type of pharmacists, if I may say. We have pharmacists that are training averse. That means they dislike long training. That considers about 15%. We saw that so it's supposed to be profit driven. So there are 30% of pharmacists who are profit driven. These are pharmacists who want high margin and simple services as public health intervention. And then we are seeing that 55% of pharmacists, which are the majority, are capacity oriented. So they value both short and long term training. So what does that mean? So this means that there is a higher preference for PHI, that's number one, that require moderate training, composing that both and short term and long term there. So that is moderate training that does not interfere with their day-to-day practice, highlighting the importance of capacity development. So maybe how does this point relate to this? So obviously more details has been laid down in the paper. However, a summary is, over here we see that profit margin is something that really drives community pharmacists on whether or not they will take part in a public health intervention. However, for it to be in this number, we can see that it's not only profit margin alone that sort of drives that need for community pharmacies to pick up PHIs. However, it is you as whoever is designing this public health intervention to package it in a way that is capacity oriented for the pharmacy, for them to pick it up. So if you want to appeal to pharmacists and you want them to take up a public health intervention, there are different type of pharmacies in which you can speak to. Number one is that they will obviously go for the profit margin. That's number one. However, when you're making that intervention or public health intervention program for them to pick up, you need to consider these things. So that means that whenever I'm making a public health intervention, I won't just tell a pharmacist that this public health intervention will give you, for example, a 15% profit margin increase. No, chances are they already know that. However, if I tell them, or if I let them know that this intervention is capacity oriented, that means I will be appealing to 55% of the pharmacists. I don't know if that makes sense. So this is very important when you're designing a public health intervention. So this result tells us that, number one, when I'm designing a public health intervention, I want to have the profit margin for these pharmacists in mind. And number two, when I want to deliver it to them, I want to target more so and make the program or public health intervention more capacity oriented. So in that way, you are able to address these two problems that we are facing over here: uptake and actually uptake mostly. So this one now is much dependent on national health strategies. I haven't talked about it here, but you can see for the uptake to be a bit consistent, you have to appeal beyond the profit margin. Even though they want to make business, they want to feel that the public health intervention is more capacity oriented. I hope that explanation is a bit clearer. All right, so the policy implication for this paper is that number one, to make the intervention to work, the economics must work first. All right. So because that involves 3/4 of the decisions, you see more than 75%. Number two, default to simpler intervention, reserve complex one for providers who choose them and price them. So if you take a deep dive in the paper, you will see that for pharmacists to pick up complex intervention, there's a certain amount of money that needs to be attributed to it. I won't mention it here, but again, have a look at the paper, please. And number three is that build 1 to 2 day training, not weekly long courses that disrupt business. So this speaks to this point over here where we said we want moderate training for public health interventions for these pharmacists to integrate them within their workflow. All right, don't make them a week-long training. Make them 2 to 3 days at the very most for them to pick them up. Number four, subsidize equipment, especially for smaller pharmacies that lack capital. And number five, stop framing government support as subsidies and circulars. So build genuine public-private partnerships that recognize pharmacies as strategic partners, not an afterthought. So this is important because, as we saw here, government support was the least in terms of the how you would package your public health intervention. If you had packaged my public health intervention as government oriented or government supported, community pharmacists will highly likely not take it up. And then within it, if there's a financial component, maybe they will consider it. Okay, so that means that whenever I have a public health intervention as the government, as a regulator, I wouldn't lead with it being a government supported or subsidiary. Rather, I would want to co-create with the pharmacists within the region for them to likely take it up. I think these are the policy implications that I got from this paper. All right. So just to finish up, this is more of a career angle, not largely related to the paper, but largely what we do as Afya Data. If you want to think in this direction, I think part of our mission as Afya Data, we like to introduce data science to pharmacy. And in this case, I've gone the health economics way, but there's a little bit of machine learning that you can throw into health economics, maybe apply to pharmacy, apply to regulatory bodies, and for example, in similar settings. And the whole essence is that this provides learnable skills for pharmacists. So wherever you are at work, maybe BPP, Ministry of Health, NGO, if you have such skills, they are an add-on. So that's what we believe here at Afya Data. So yeah, join the community where we at the moment we sort of work on lightweight tools at the intersection of pharmacy, data science, and regulations. And then we talk about broadly about things about guidelines, policy breakdowns, machine learning and data science workflow in pharmacy, and also cool papers spreading from health economics, particularly to pharmacy, so more pharmacoeconomics, and yeah, anything that has data that involves medicine, to say yes. And we also do deep dives in data science and data science methodology, and actually currently we are very interested in computational models in life sciences. Okay, so that's everything in a nutshell. Yeah, so thank you. I really enjoyed making this video, and if you enjoyed such content, please make sure to leave a like, subscribe, hit us in the comments as we explore this field. Until next time, it's been your host, David Andai. Bye bye.